So here the cellulitis, the patient present will in GP setting, and 55-year-old man present with painful red swelling on his right lower leg for past 3 days, and patient report warmth, tenderness and mild fever, and no trauma or insect bite. So you will ask in the history, did you sustain any trauma to your leg or any insect bite? There will be no insect bite, no trauma, but the leg will be warmth and tender, and there will be the mild fever as well. And the patient is non-diabetic on metformin and worried it might be blood clot. So key question you will ask, any cough, pain, swelling, tenderness suggestive of DVT? So no cough, tenderness, swelling are limited to lower leg. Any blister, necrosis or severe pain out of proportion? So no. No blister, no necrosis, and no severe pain out of proportion. Any systemic features, fever, confusion, tachycardia? Yes, fever is present, no systemic upset. Any new wound, ulcer or scratches on legs, small fissure between toes noted. And any recent travel, immobility or anticoagulant use? No travel, no immobility, no anticoagulant use. So Maftosa asked about the past medical history, metformin twice daily, and there is no known history of family, no known allergy history, no recent travel, retired mechanic and non-smoker, and alcohol use occasional. And then HbA1c is 7.5, mean uncontrolled sugar. And then ideas think it could be the blood clot infection, concern, worried it might spread or affect the diabetes control, hope for antibiotic advice on care. So then on examination you will see erythematous, warm, swollen and tender right lower leg, and the margins are poorly demarcated and consistent with cellulitis. There are no margin demarcated, no cough, tenderness, pulses palpable, and no pitting edema is present. Pulses will be present and no pitting edema will be there. So afebrile, low grade fever, and investigation you can request for blood test to see for the infection, WBCs and inflammatory marker, CRP, and if DVT suspected, then you will arrange Doppler ultrasound for the DVT suspicion. And HbA1c and glucose control, you can check the HbA1c. And cellulitis, explain the diagnosis. It is actually cellulitis of the right lower leg, that is due to bacterial skin infection, likely Staph aureus or Staphylococcus aureus or Streptococcus, with the patient with diabetes. And this redness and swelling are caused by skin infection called cellulitis. It happens when the bacteria enter through the cracks or breaks in the skin. Because you have diabetes and your skin takes longer to heal, so it's important to start antibiotics early and keep the area clean and elevated. And in management plan, what the patient self-care, what patient can do: keep the affected leg elevated and reduce swelling, stay hydrated and rest, keep the skin dry and clean, avoid scratching, monitor for any increase in redness, swelling or fever. What doctor can offer: we can give the oral flucloxacillin 500 mg 4 times a day for 7 days, and if penicillin allergic patient, then doxycycline 100 mg twice daily for 7 days. So treatment will be the for 7 days in cellulitis, but if flucloxacillin, then 4 times daily, and doxycycline then twice daily. And flucloxacillin will be 500 mg or more. Borders of redness with the pen to monitor the spread and review diabetic control and optimize food hygiene. And if systemic symptoms are rapid progression or poor response, admit for IV antibiotics, comoxiclav or flucloxacillin IV, and seek urgent help if fever and chills and confusion or vomiting or spreading of redness occur, and report immediately if a new blister or necrosis or numbness develop, and advise to return in 48 hours for review or earlier if worse, and review in 2 days to see the improvement.